Good evening. Good evening. Yeah, nice. So we have completed two programs. So quiz and then scope of diagnostic center CF hospital and the CM insurance schemes. Two sessions over of today IMA CME program. And we have came for this final session, OP management of type 2 diabetes mellitus update 2022. Before that, so we are very happy to have all of you and especially Senthil sir and all the dignitaries. Just I'll introduce you soon. And this is my privilege to have all our dignitaries. So we want to welcome all of the doctors from CF Hospital, the doctors from the outside the CF Hospital, Vatanchitram and Palani, and then all the local pediatricians and all the doctors. So we want to welcome you on behalf of CF Hospital and IMA Vatanchitram. And then I'll take this privilege to welcome our dignitaries. So Dr. Senthil sir is our president, Tamil Nadu Medical Council. Sir, so we are very happy to have you, sir. We want to welcome you. And then it's my privilege to welcome IMA President, Dr. Karpanan sir. Sir, yes. Yeah, he's our IMA President, Vatanchitram branch. We welcome you, sir. And this is my privilege to welcome Vice President Muthuswamy sir. Sir, we want to welcome you, Vatanchitram branch. And then we want to welcome and then part of more enthusiastic and energetic, even like a MBBS doctor, that much energetic, Dr. Asay Thambi sir, our Secretary IMA Vatanchitram branch. We want to welcome you. Sir is very, very energetic and always is the first row for everything. Sir, we want to welcome you, sir. And then this is my privilege. I'll take to welcome our medical superintendent, Dr. Anish. So you know our young dynamic medical superintendent. And then this again, I'm taking my privilege to welcome you all for this CME program. And this is the first program. Just I want to thank God for His grace. As an institution, we got accreditation for the CME program credit hours. We got the accreditation yesterday around 12:30 p.m. We got. So we want to thank God and we want to glorify His name. And then special thanks to Senthil sir and our sister Gayatri from TMNCI. They helped a lot. We want to thank you, sir, once again. And then from now onwards, all the CME programs, our institution can avail all the credit hours. And now this is my time to welcome Valsa ma'am to lead us in word of prayer. We'll start our program with word of prayer. It's my request. I'll request Valsa ma'am to lead us in prayer.
Shall we all stand up? Oh God, our Heavenly Father, we want to thank you, Lord, that as IMA, we all can come together for a time of learning best practices, that we can give the best care for the patients whom we serve. We pray that you will guide our discussions, our teaching, that we will learn the best practices. Thank you, Lord, for allowing us to have the CME credit hours available here itself. Help us to make use of it in the best way. We commit the rest of the program into your hands. In your precious name we pray. Amen.
Thank you, ma'am. So now I request our medical superintendent have few words. Dr. Anish.
Good evening. Good evening. Thank you. Thank you, Dr. Ramesh, for the words of welcome. And on behalf of our institution, we would like to welcome each one of you, especially the guests on the dais. Dr. Sendil, thank you, sir, for coming and gracing this occasion. Especially, we want to thank the IMA who was behind us to get this thing started. And actually, this is the first of its kind where we have CME and which will be having credit points. And what I heard is it's mandatory from now onwards that all doctors need to have credit points once they need to re-register. So we thought about it and we thought, let's start it here. And when we approached Dr. Sendil, he said, an institution of this size, you should have started much before, but not late. We are on time. So thank you, sir, Sendil sir, for helping us to get it started. And we're going to have a series of lectures once a month. So this is a humble beginning of a series of lectures every month. And it'll be under the IMA and in banner of our institution too. Dr. Sendil, as Dr. Ramesh told, he's the president of the Tamil Nadu Medical Council, the present president, and he's also standing for the next president. His term is getting over, and he's also standing for the next elections that's coming up. It's around the corner. And he's a professor in medicine in Madurai Medical College. And his wife is an obstetrician and also working in Madurai Medical College. Thank you, sir, for accepting our invitation. Even though it's almost 2.5 hours journey through the road, sir said he will make it. So thank you, sir, for coming. Also like to thank our President, Karpunan sir, and Asatambi sir for coming and gracing this occasion. And also like to thank our dear doctors in Ottanchitram. Thank you, sirs and ma'ams. And also we have guests from Amblike. We want to thank you for coming and for taking part in this inaugural function. Yes, these times are times where we learn together and also to get to know each other. So we pray that we wish that this time would be an interactive session and also to interact with others. So I encourage each one of you to find someone new and talk to them and introduce yourself so that we'll get to know each other. I would also say the vote of thanks because we are all be running late. So I want to thank the working team, the working secretaries, Dr. Ramesh and Dr. Joshua. Can we have a round of applause to both of them? It all dawned yesterday that we were eligible to conduct the CME with credit points. And they worked from yesterday morning till evening. And usually it takes a week's time to get these things accredited. But through hard work of Dr. Ramesh, Dr. Shalom, and Dr. Joshua, along with Dr. Sendil and his secretary, we were able to get this. So we want to thank the working team and also the institution, Mr. Vinod and Hajib, who have helped us with the Zoom. When we put this across, many people asked, can we have a live Zoom streaming? Because many of our alumnus wanted to also join and take part in this session. So it was made possible for that too. So you can send the links to your friends if they're interested. And also Dr. Cijoy, who has agreed to take a class on OP management of diabetes. So thank you, Dr. Cijoy, for accepting that. So I will not take much of time. At this time, I'd like to felicitate our Tamil Nadu Medical President, Mr. Sendil Kumar. On behalf of IMA, I request Dr. Asatambi sir to grace him with a shawl. Our President, Dr. Karpunan, will grace Sendil sir with a shawl. On behalf of Christian Fellowship Hospital and Society, I request Dr. Joseph Nelimalai, Chairman, to grace Sendil sir with a shawl. Thank you. I hope you have a nice time. I welcome sir to share a few words.
Respected medical superintendent of the institution and the president, secretary and office bearers of the Indian Medical Association, and Dr. Ramesh and Dr. Joshua and other learned dignitaries and students. Good evening, all of you. I am Dr. Sendil, and as I have been introduced, I am working as a professor of medicine in Madurai Medical College. And of course, I am born and brought up in Madurai, and presently the president of Tamil Nadu Medical Council as well as the member of National Medical Commission. I'm really happy to be here. So this part, I was told that there will be a regular academic sessions in this institution, and they have been applying through IMA Vatajadram branch for credit hours. When I learned that this organization has the postgraduates as well, it's a teaching institution with about 40 postgraduates as well as 300 bedded hospital, I was really shocked. I was surprised why they have not applied directly to the Medical Council for accreditation, and they duly deserve it. And on one side, it is a failure on our part, that is the Medical Council part, to reach all those bigger institutions, especially teaching institutions, to get creditors. And it's not only benefit the students or the doctors of that institution. In due course, when it is going to be elaborated with the next regulations by the National Medical Commission, which is very particular on that, say then possibly it will be notified in this way in a month's time. In the latest regulations, I was part of the 10-member expert committee by the National Medical Commission, which drafted that regulations. And it contains that till now it was a creditors, which is mandatory. And if you don't accrue the required creditors, we will not force it, and there is no binding clause on that. Now with the NMC regulations, they insist that every doctor should renew their license once in 5 years with the needed credit hours. So it is going to be mandatory. And every one of you, apart from that, the doctors in and around Vatanjatram, especially the private and government doctors, will be benefited if the organization can conduct CME and conferences regularly. And of course, as of now, we have some 600 accredited organizations in Tamil Nadu Medical Council, in which some 400 are active and some 200 are not very active. And hopefully, we want more organizations to be accredited. That is roughly about 1,000, so that it will cater the needs of the biggest state medical council in India, that is Tamil Nadu Medical Council, which has some 172,000 registered medical practitioners. It includes Tamil Nadu, Pondicherry, and Andaman and Nicobar. And this is the oldest state medical council as well. It was started way back in 1914, and it has a lot of credits to its to the organization. And since the inception of National Medical Commission, we have a good interaction with that body, and of course they regularly consult Tamil Nadu Medical Council in most of the issues, because this is one of the latest and experienced medical council, and it has a lot of office bearers who are well versed in the rules and regulations. And I'm happy that the IMA as well as the organization is conducting regularly, and it's very unusual for me to have academic session at this hour of the day, that is late evening, and I'm really happy. In a way, I feel that after a break, if you are going to have a small session, and of course, TNMC insists that it should be at least 2 hour session. Definitely, you will be able to be fresh and you can grasp better things than continuous classes in the afternoon or in the evening. And we have a lot of qualified personnel here in this institution. And I was told today's topic was about diabetes, and definitely it's one of the most essential subject every medical practitioner should know, irrespective of the specialty they do. Basically, they should know about diabetes. And as you know, diabetes is such a small field. Being a physician, we know that diabetes is such a small subject, though you cannot master it, but the basics everyone can easily, if they have some interest and if they can spare some time, definitely they can know. And with the speakers who are yet to speak, and they will definitely enlighten you with more practical as well as theoretical points, both in examination as well as in practical points. Uh, and when I just accidentally met Dr. Asetambi and Dr. Muthusamy a day before, I was told that Christian Fellowship, of course, I heard of the institution, but I didn't know the number of beds or the number of doctors working here, and especially it is a PG institution. And it was a surprise. And of course, with due interaction with the medical superintendent as well as Dr. Ramesh, we were able to provide the accreditation for this organization in a day's time. And it's all to tell you briefly about the Tamil Nadu Medical Council in the last 5 years. We have almost fully digitalized, and I think seeing the faces, I think many students are from other states. Is it? How many of you from other states? Okay. Of course, it is essential that all the other state postgraduates should also register in Tamil Nadu Medical Council within 3 months of joining the course. Okay. Otherwise, we are actually imposing a penalty, and hopefully, I don't want you to pay that. And so better at the earliest, please apply for get a NOC from your parent state medical council, and then apply here. It's all online, but of course, once you may have to visit the council, and you have to be there hardly for 10 minutes. Everything will be done, scrutiny, everything will be done online. Only for physical verification of the certificates and the photograph and biometric verification of the Aadhaar, you have to be there. It will hardly take 10 minutes. And so other doctors who are here would have already gone there, especially if they had completed their MBBS in the last 2 years. And it is fully digitalized and paperless. And now the CME is also, we have this kind of accreditation and other things. And those doctors who are practicing in Tamil Nadu, Pondicherry and Andaman, they can get creditors only through organizations. They cannot get a creditor on their own. So if they need creditors, they have to enroll themselves with the organization, and they on payment of a nominal fees, that is 25 rupees per credit hour. That is, you have to accrue 6 credit hours a year. And another one happy point you all should know is this kind of teaching institutions, even if they don't get credit hours, by virtue of their experience in teaching institution with regard to those subjects, the specialists concerning that teaching subjects, that is the dependent subjects, will be given credit hours automatically, 6 credit hours a year. And of course, on payment of a nominal fees. And if you have not already credited, you can either way you can get the needed credit hours. And of course, if NMC regulations is gazetted, and that will, again, we will be starting afresh for the next with the latest regulations imposed by the NMC. And apart from CME and other thing, I mean, there is registration. The other thing is disciplinary cases. You all know that the Tamil Nadu Medical Council is not an association. It is a regulatory body. It's a medical regulatory body, and it has to regulate. One is registration, another is regulation. And it will deal with all cases of alleged misconducts as well as negligence, medical negligence. And as you know, 2 days back also some mishap has happened in last week, some mishap happened in Chennai, and two doctors are being harassed, charged under criminal negligence. Actually, in fact, the specialists have given it is not a criminal negligence, it is a civil negligence. But in spite of that, with the high-handedness of the police and the inactiveness of the concerned officials in the government, they have been charged under criminal negligence. And now we have tipped the government that it cannot come under criminal negligence, and government has understood their mistake, and hopefully it has taken to the notice of the Honorable CM, and hopefully such drastic measures like doctors' arrest has been stopped, and they have assured that it will not be done. And maybe in a week's time, they will convert the FIR also. So it has, it's not against the doctors, it will be just a suspicious death. As you know that any MLC cases will be booked under section 174 CRPC, that is suspicious death. So the third main objective is the regulation with regard to misconduct and negligence. And fourth main function is eradication of quackery. That was recently in the earlier MCA Act, that was not there. But in the recent NMC Act, they have delegated powers to all the state medical council, and we have already started acting against the quacks. And in due course, maybe in another 2-3 years, we will see that such quacks will not be there, harming the public. And this is the introduction about the Tamil Nadu Medical Council. And I have been the president of Tamil Nadu Medical Council for the last 7 years. I was a member even in the previous tenure. This is and I am contesting for the third term now with a batch of our colleagues. And I appeal to all of you to consider voting, and it will be a postal vote. The ballots will come to your registered address. Whatever address you are given in the TNMC, when you registered, for that address, the postal ballots will come in the last week, that is after 19th. That will be before, possibly before Christmas. You will all get your ballot paper, and you have to vote for 7 people. Out of about 40 candidates, you have to vote for 7 people. And I just circulate the pamphlet so that you can also know the other candidates as well. And please vote for this team. And it is up to you. And of course, we assure that we will continue our good services, and will be upholding the prestige image of medical profession and the medical practitioners. Thank you. Thanks for this opportunity.
Yes, sir. Thank you, sir, for your kind words. And so for us, lack of time, we want to invite all of main dignitaries, but we don't have enough time. Just it's already 9 o'clock, and this is the time for only our IMA President Karpanan sir to share a few words. After that, so there is a prize distribution, and after that we'll go for class. Thank you, sir. I request sir to share.
முதலில் அனைவரையும் வரவேற்று என் வணக்கத்தை தெரிவித்துக் கொள்கிறேன். ஒட்டகத்திரம் ஐஎம்ஏ என்பது கொஞ்சம் ஸ்லோவாக ஃபங்க்ஷன் ஆகிட்டு இருந்தது. இப்போ ஒரு ஆக்டிவாக ஆக ஆரம்பிச்சிருக்கு. அது டாக்டர் வேமனன் அவர்களுக்கு தான் ரொம்ப நன்றி சொல்லணும். அதுக்கடுத்து டாக்டர் ஆசை தம்பி அஸ் யூஸ்வலாக அவர் கொஞ்சம் ஆக்டிவாக இது பண்ணிட்டு இருக்காரு. முத்துசாமி இவங்க இது பண்ணிட்டு இருக்காங்க, வைஸ் பிரசிடென்ட். அதனால மறுபடியும் இந்த ஐஎம்ஏ ஆக்டிவா செயல்படுறதுக்கு இது பண்ணனா அவர்களை உண்மையிலேயே மனதார வாழ்த்துகிறேன், வரவேற்கிறேன். அடுத்து டாக்டர் சிஜாய் குரியகோஸ், அவர் ஏற்கனவே இங்க ஒர்க் பண்ணிட்டு இருந்தாரு. அப்புறம் இப்போ பிஜி முடிச்சுட்டு மறுபடியும் இங்க வந்திருக்கார், சூப்பர் ஸ்பெஷாலிட்டி முடிச்சுட்டு. இஸ் அ வெரி குட் பிசிஷியன். அதனால அவர் இந்த பக்கம் இந்த இன்ஸ்டியூட்டுக்கு வந்தது எங்களை போன்ற டாக்டர்களுக்கு உண்மையிலேயே ஒரு பிரயோஜனமா இருக்கும், யூஸ்ஃபுல்லா இருக்கும். அதனால அவரையும் நான் வரவேற்கிறேன். ஏன்னா அடுத்த அவர் தான் பேச போறாரு. இப்போ டாக்டர் செந்தில் அவர்களை பற்றி ஒரு சில வார்த்தைகள் மட்டும் நான் சொல்லிடுறேன். டாக்டர் செந்தில் சார் அவர்கள் இப்போ தற்சமயம் தமிழ்நாடு மெடிக்கல் கவுன்சிலுடைய பிரசிடென்டாகவும் தமிழ்நாடு கவர்மெண்ட் டாக்டர்ஸ் அசோசியேஷன் பிரசிடென்டாகவும் செயல்பட்டு கொண்டிருக்கிறார். கடந்த பல வருடங்களாகவே ஆக்டிவாக இருந்து வருகிறார். குறிப்பாக டாக்டர்ஸுடைய கோரிக்கைகளுக்காக போராடும் போது அவருடைய பங்கு என்பது மிகச்சிறப்பாக இருக்கும். அதனால இப்ப அடுத்து டாக்டர் பிரகாசம் அவர்கள் இப்ப நேஷனல் வைஸ் பிரசிடென்டா இருக்காரு. டிஎன்ஜிடிஏ ஃபவுண்டர் பிரசிடென்ட், நம்ம தமிழ்நாடு ஸ்டேட் பிரான்ச் ஐஎம்ஏ பாஸ்ட் பிரசிடென்ட். அவர் he is a dynamic worker even at the age of around 70 years. அடுத்து டாக்டர் என்ஆர்டி தியாகராஜன், அவர் தேனி டாக்டர், ஒரு யங்ஸ்டர், மிகவும் ஆர்வமாக இந்த ஐஎம்ஏவில் ஒர்க் பண்ணிட்டு இருக்காரு. ஆனரி செக்ரட்டரி, ஸ்டேட் செக்ரட்டரி அவர் தான். அடுத்து டாக்டர் ஜெயலால், இங்க டாக்டர் பால் மற்றும் சிலருக்கு அவரை பற்றி நல்லா தெரியும். ரொம்ப சிறப்பாக ஐஎம்ஏவில் இருப்பார். எல்லா ப்ராப்ளம்ஸையும் சால்வ் பண்ணுறதுக்கு, இது பண்ணுறதுக்கு தன்னால் முடிஞ்ச அளவு எல்லாம் செய்வார். அவர் இந்த டீமில் இருக்கார். அடுத்து டாக்டர் MS அஸ்ரப், திருச்சி, அவரும் பல வருடங்களாக, கிட்டத்தட்ட எனக்கு 1997 தெரியும், இன்னும் பல வருடங்களாக அவரும் ஆக்டிவாக ஒர்க் பண்ணிட்டு இருக்கார். அடுத்து டாக்டர் ஜெய்சிங், டாக்டர் தளபதி சராச்சரன், இவர்களும் இருக்காங்க. ஆக இந்த டீம்ல தமிழ்நாடு மெடிக்கல் கவுன்சில் எலெக்ஷன்ல இந்த 7 பேர் கொண்ட ஒரு டீம் டாக்டர் செந்தில் சார் அவர்கள் தலைமையில் நடந்துட்டு இருக்கிறது, ஒர்க் பண்றாங்க. நான் உங்களை கேட்டுக்கொள்வது என்னன்னா, இவர்கள் தேர்ந்தெடுக்கப்பட்டால், அதாவது சிறப்பாக வேலை செய்வார்கள். நம்ம டாக்டர்ஸுடைய போராட்டங்கள், அவர்களுடைய முன்னேற்றம், அவர்களுக்கான கோரிக்கைகளை அரசாங்கத்துடனும் மற்ற பல வழிகளிலும் வாதாடி சிறப்பாக அதை இது பண்ணி தருவார். அதனால நாங்கள் உங்களை கேட்டுக்கொள்வது, நாம் அனைவரும் அவர்களை ஆதரிக்க வேண்டும் என்று நான் கேட்டுக்கொள்கிறேன். அடுத்து டாக்டர் சிஜாய் குரியகோஸ் அவர்களை இந்த outpatient management of type 2 diabetes mellitus and its update அப்படிங்கிற டாபிக்ல பேச இருக்கிறாரு. அவரை பேசுமாறு உங்கள் சார்பாக அவரை வரவேற்கிறேன்.
Thank you, sir. Now, this is the time for quiz winners. First, second, third place. It's my privilege to have Senthil sir to give the prizes for them. So we have conducted quiz, exclusively diabetes chapter, 50 questions, and the 25 questions from IMA, Asha sir has prepared, and remaining questions from our CF hospital physicians team, and so diabetes Cijoy sir and Dr. Joshua, they all helped. Out of 50 questions, they are very tough actually. So we got third place, 33 marks, Dr. Aravind Kishan. So yeah, Aravind, shall I ask him to forward to, may I request Senthil sir to give the prize for the first year general medicine PG, Dr. Aravind Krishnan. Yeah, third place, sir. He's our first year PG. We want to congratulate you. He got 33 marks out of 50. Yeah, thank you. Now, second place, Dr. Aravindan, 35 marks. 35 marks out of 50 marks. Congratulations, Dr. Aravind. And first place goes to Dr. Navinith Krishnan. He got 37 marks out of 50. So very two marks difference only. So he is our final year PG, and even Dr. Aravind is also our final year PG, sir, general medicine. Yeah, thank you very much. And this is my time to ask my co-organizing secretary, Dr. Joshua, to introduce our speaker today session.
Good evening. It's my honor and privilege to introduce today's speaker, Dr. Cijoy Kuriakos, someone whom I look up to and is an inspiration to many young doctors like me. Dr. Cijoy did his MBBS from Kozhikode Medical College. He belongs to the batch of 94. He did his DNB medicine training from CFH Ottanchitram, which he completed with a national gold medal in the year 2005. He had been working in the Department of General Medicine in CFH since then. He did his postdoctoral fellowship in endocrinology from CMC Vellore in 2017. Following this, he rejoined the Department of General Medicine in CFH Ottanchitram. He has multiple publications in index journals, both national and international. He is an invited speaker and panelist in many national conferences. He's an astute clinician and an excellent teacher. We are privileged to have you, sir. Over to you.
Thank you for your kind words. I want to greet all the dignitaries. Special thanks to Senthil sir also for all the help that we have received and for gracing this occasion. For the brief time that we have before us, we will quickly go through some practical aspects and some updates on a very common topic, that is type 2 diabetes. As sir was rightly mentioning, there is no escape for a doctor from diabetes, because anywhere you go, you will be asked questions about diabetes, whether it is in a train journey or in a family function. You will be bombarded with questions about diabetes, whatever your specialty, not only from your patients, from neighbors, from relatives, anywhere, even co-passengers, you will have to face questions about diabetes. So what I'm trying to see is, of course, diabetes is probably a topic that many people will cover in 3 years. So I'm trying to do that in 30 minutes. What we'll be concentrating on the latest updates on diabetes management, an overview of what we need to know in our general practice. That is what my focus would be. The focus of the talk will be on the burden of diabetes in the world and in India and in South India, in Tamil Nadu particularly, classification of diabetes, what are the updates on that, what are the current guidelines for screening and diagnosis of diabetes, and a little bit more on the management of diabetes. So I have mainly taken from the American Diabetes Association to 2022 guidelines, the RSSDI guidelines, which is the Research Society for Study of Diabetes in India. That has also been published recently in September 2022. The last month only we had the consensus statement from ADA and the European Association of Study of Diabetes. That consensus has come in the last 2 months back. These are the main sources. Wherever other sources have not been acknowledged. Most of the statistics I have taken from the last year's International Diabetes Federation Atlas. This is something that comes every few years, and that gives the full statistics of the diabetes profile all over the world. So just briefly going through the burden of diabetes, the global prevalence in 20 to 79 years, the adult age group is around 10.5%, which means 1 in 10 or 1 in 11 adults in the world are affected by diabetes. In hyperglycemia in pregnancy world over is almost 16.7%, which comes to 1 in 6 pregnancies are affected. 1 in 6 live births are also affected by some sort of hyperglycemia. The incidence has been fairly stable or declined in the high income countries, whereas it has been increasing in the low and middle income countries. Can you guess which is the country in the world which has got the maximum prevalence of diabetes? Some clues there. Not the total number. Obviously, the most populous countries will have higher numbers. I'm talking about the prevalence. You can see the darker shade, which is close to India. Pakistan, very high prevalence of diabetes. Almost 16% of in the adult population has got diabetes in Pakistan, and it is projected to be like that for the next 20 years at least. You can see India comes in the next tier, where we still have quite high number of diabetes. This is about a leading death globally, not only by diabetes itself, but whatever else comes in between. Even the COVID pandemic proved to us that diabetes is a killer disease, even when it comes along with other diseases. In the low and middle income countries like India, we find that the incidence is not only increasing, 1 in 2 diabetics are not diagnosed. 50% of the diabetic people do not know they have diabetes in low and middle income countries. India has the second highest number of people with diabetes in the world because of our population. It is believed that next year or the year after that, we will overtake China as the most populous nation in the world. Most of us from our childhood, we've been always telling India is second in population. Now we have to tell that we are first in population within a matter of 1 or 2 years. India has the highest number of type 1 diabetes, even more than China. And the prevalence of Indian diabetes among the Indian population is 8.9%. 1 in 4 live births is affected. But you can see within India, there is a huge difference. You can see the profile in the southern states, very high prevalence compared to many of the northern states. Of course, there is Karnataka and Goa there, and Punjab and Delhi, a dot that you can see there with very high prevalences. There is one study from southern India with the incidence. This is not about prevalence, incidence over 10 years, which has been done from an urban pocket in southern India, which found that over a period of 10 years, among the people who have studied from those two blocks, villages, they found that 50% developed diabetes or pre-diabetes in 10 years time. In our OPD also, more than 10% of our IP and OP, would be definitely diabetes every day. So what is, this is the current burden. This is from the latest statistics. What is the current classification of diabetes? This has come from WHO in the last 2 years back, 2019. This is the latest classification of diabetes. It is now dividing diabetes into 6 types. Type 1 diabetes, type 2 diabetes, very familiar for us. And there are 2 hybrid forms of diabetes where it is behaving somewhere similar to type 1 and type 2. One is called the latent autoimmune diabetes of young, and the other is called ketosis prone diabetes. Previously, it was called as flatbush diabetes. You can, you need not remember those, but there are hybrid forms where there is some features of type 1 diabetes and some features of type 2 diabetes. Then there are other specific types. We have heard about pancreatic diabetes, diabetes due to medicines like steroid-induced diabetes, statin-induced diabetes, diabetes due to chemicals, diabetes due to some genetic syndromes. All these could be coming under the other specific types. Then there is an unclassified diabetes, which is kept only for those diabetes which is not clearly fitting into any of the other groups till the diagnosis is made. In our hospital, very often we put the younger patients whom the diagnosis has not come, we put it as young onset diabetes. That means that the full diagnosis has not yet come. That is the group which can be kept as unclassified diabetes, ultimately which may go into one of the other 4 or 5 types. Then the last one, the 6th group, is hyperglycemia, which is first detected during pregnancy, which can be pre-existing diabetes, which was detected first time in pregnancy, or it could be gestational diabetes, which is only specific for pregnancy. Both of these are classified under hyperglycemia in pregnancy. So this is the 6 groups of diabetes according to the latest guideline. How do you screen for diabetes? This has not really changed much, but all the regulatory bodies have now brought in that every healthcare provider should screen for diabetes. That is one type of screening is called opportunistic screening. The patient is coming to any hospital or clinic for some reason, not really for diabetes. That is an opportunity for screening them. Family members of patients with diabetes, all of them should undergo screening. All antenatal patients, all patients who go for dental care, and even overweight children and adolescents at the onset of puberty itself, they should be screened for diabetes. Apart from this, all the governments are now behind this community screening of diabetes wherever feasible, and universal screening of pregnant women. How do you screen? One could be to ask a high risk, are you at high risk for diabetes? There are various high risk questionnaires available. This one is an example from ADA itself. There are many other high risk questionnaires that you can find in any Medscape. Will have 2-3 high risk questionnaires to find out what is your risk of developing diabetes. Those who have a risk will have to undergo at least a random glucometer red blood glucose levels, followed by a confirmation test for those who are screening positive. Either you can do an OGTT or glucose tolerance test or any other, even an ACPC would do, but those who are at high risk, screen them. That is the most important thing. So in ADA 2022 guidelines, the American Diabetes Association guidelines, what has changed? One important change is that previously used to say after 45 years you have to screen for diabetes. Now the thing is after 35 years you have to start screening for diabetes for adults, even without those without risk factors. Second is screening with a fasting glucose for all women planning pregnancy. This is to catch up with all the gynecological societies yet, but all women 24 to 28 week, that guideline still holds true, but still apart from that, all women who are especially at high risk till now has to be screened even at the first antenatal visit itself. That is for planned pregnancies, unplanned pregnancies, and for planned pregnancies, even before they conceive, they have to be screened for diabetes. How do you diagnose diabetes? This has fairly remained the same for the last 2 decades. Almost 15 years it has been the same. When somebody's HbA1c is normal is less than 5.7, 5.7 to 6.4 is pre-diabetes, and above 6.5 is called as diabetes. Fasting glucose less than 100, that is up to 99 is considered as normal. 100 to 125 is borderline or pre-diabetes. It is otherwise called as, if it is fasting, it is called impaired fasting glucose, and more than 126 is diabetes. When it comes to glucose tolerant test or postprandial glucose, it is 140 below is normal, 140 to 199 is pre-diabetes or otherwise called as impaired glucose tolerance, and above 200 is diabetes. This has not changed much. Random blood glucose also, if there is associated hyperglycemic symptoms, you can directly diagnose diabetes even with one single value. Most of the others in asymptomatic patients, you have to have 2 values to diagnose diabetes. HbA1c, you don't need to have 2 values. When do you have to doubt that this patient may not be having type 2 diabetes? Of course, 90% of all diabetes in the world is type 2. When should you have a warning sign, a red flag raised that it may not be type 2 diabetes? When the onset is below 35 years, when the patient has a low BMI. Of course, India is known to have lean type 2 diabetics. There are many clusters of that. We won't go into that right now. If there has been a prevalence of more than 50% in every generation of a family, you should suspect that is it something other than type 2 diabetes. History of abdominal pain or steatorrhea as a clue towards pancreatic diabetes. Presence of diseases or use of drugs which predispose to hyperglycemia. Some people have very brittle diabetes, suddenly increases. It is 400 in the morning, then 60 in the evening. This kind of diabetes makes us doubt, is this really type 2 diabetes or is it something else? These are some warning signs or red flags for us to screen for diabetes which is other than type 2 diabetes. Coming to the management, we use what is called as the 3C approach for diabetes. Any diabetic patient, whether you meet him on the road, in the ICU or in the ward or in the OPD, there are 3 questions that you have to ask yourself when you deal with a diabetic patient. The first question is the patient's diabetes or glycemic level controlled? Second question is, have I prevented, detected, and managed diabetes-related complications? Third question is, have I prevented, detected, and managed diabetes-related comorbidities? These are the 3 questions that we need to ask. The same 3 Cs you can use for any lifestyle disease. You can apply it for dyslipidemia, you can apply it for hypertension. The same questions. Is it the primary problem controlled? Have I looked at the complications of the primary problem? In this case, diabetic complications and comorbidities. Have I looked for that? What are the complications? We know that there are acute complications and chronic complications. In the chronic ones, we mainly focus on the vascular complications because they are the silent killers. Microvascular, you know, the triopathy, three organs involved in microvascular and 3 organs involved in macrovascular. Which are those 3? In microvascular, it is the eye, the kidney, and the nerves. In macrovascular, it is coronary artery disease, cerebrovascular disease, and peripheral vascular disease. Very easy to remember. 3 micro, 3 macro. This is the general complications. When it comes to comorbidities, there are so many comorbidities of diabetes, hypertension, dyslipidemia. These are all more common in patients with diabetes. Cardiac diseases, thyroid disorders, obesity, osteoarthritis, PCOS, skin diseases, soft tissue disorders, GI disorders, all are much more commoner than the general population in diabetic patients. So we need to probably look at that. Particular importance has to be given in the first 3, hypertension, dyslipidemia, and cardiac diseases. We'll be coming to that. Coming to the control. Control, again, you can look at how do you control diabetes? Of course, you have 3-pronged strategy. One is about diet, second is activity, physical activity, and third is medications. Diet. What is an easy way of explaining to your patients and an easy way of practicing yourself and in your family is this is called the plate method. It is very simple in that sense. You are not calculating the calories or anything. Generally, we say that 50% of your plate on every major meal has to be full of non-starchy vegetables and some fruits which are not very, very sweet. This will comprise of 50% of your plate. 25% of your plate can be carbohydrates, which includes most of the cereals. There are, of course, some differences between rice and wheat and all those things. The other types of whole grains, there are different advantages and disadvantages for each of them. We won't go into that, but the plate method is very easy to explain to patients. Then the other 25% is mainly protein, which can be all the pulses and legumes. Even some of the non-vegetarian food also will come under the 25%. So 50% non-starchy vegetables and some fruits, 25% of carbohydrate and 25% of protein would be a very simple way of explaining the whole complex thing of diet to your patients. So in patients who are taking insulin particularly, you may have to ask them to take an in-between mid-meal snacking. This is to prevent your blood glucose levels from going too down and then you becoming very hungry and then eating too much and then it goes a postprandial high. This sort of a fluctuation can be reduced by splitting your meals into 3 meals and 3 snacks. This is not mandatory for every diabetic, but for those who are on insulin, those who have fluctuant sugars, those who are at high risk for hypoglycemia, this may be a good thing. There is no standard diet for everyone. It has to be customized for each patient. At least once a year, diet consultation will also be helpful for patients. Secondly, it is activity. Activity has come in a big way in the newer recommendations. I'm mentioning some of them from the latest ADA, EASD consensus that I've mentioned. It has so much of advantages in insulin, production glucose, blood pressure, HbA1c, lipids, the general physical function of a person, even mental function of a person and the quality of life. All these are touched upon by exercise. This is from the ADA. There are different things that they mentioned. One is sitting. What is about sitting? I'm not expecting you to read those things. I'll come back to that. What is about sitting? Our 24-hour physical behavior matters. Sitting means the concentration on sitting. All are S, you can remember. Sitting means you should not sit for a long time. Prolonged sitting, breaking up. Even for an IMA session, you may have to break up in between. Limit sitting. In between sitting, you should get an regular bouts of slow walking or simple resistant exercises. Second S is stepping. Keep moving. Okay, you don't have to always say that 10,000 steps in a day. Many of you would have already put the pedometer in your mobile phones. 10,000 step is not a magic number. Even a 500 step extra from what you've been doing now has been shown to have a significant improvement in your metabolic profile. Any exercise, even though you are not able to achieve the targets, any exercise for that matter will help. Stepping. Little more vigorous will be sweating. Sweating exercise, basically 150 minutes per week. At least 30 minutes a day for at least 5 days a week without more than 2 days gap in between. This is a good exercise prescription. This is called an exercise prescription. Moderate to vigorous activity. That is the third S, the sweating. So sitting not for long, stepping, sweating. Then there is strengthening also may come under that. There is another important aspect that has been found is about your sleep. What is the quantity of your sleep? More than 8 hours and less than 6 hours. It's a U-shaped curve, it seems. If you sleep too much, also not good for your health. Too less, also it is not good for your health. It is somewhere between 6 and 8 hours that has been found to be very useful for adults. What is the quality of your sleep? And what is the chronotype? Are you a night owl or an early bird? The people who sleep late and get up late are more prone for poor glycemic control, interestingly. This is from the latest ADA guidelines. Okay. Finally, I'll go to medications. Of course, many of you would want to listen about medications, but we do not have much time. I'll take questions in the end. So if you have questions, we will probably deal with that later. So when you come to medications, these are the 4 pillars that the ADA and the ASD mentions. One is about the glycemic management itself. Second is the BP management for a diabetic. Third is the lipid management for a diabetic. And there are some important aspects of agents or drugs which will affect the cardiovascular or kidney morbidity. So first, glycemic management. There is a concept called the time in range. How many hours in a day your glycemic control is within the range that is acceptable for your particular patient characteristics. So what is ideal control? That has to be first defined. So the individualized glycemic goal has been a one major change that has happened over the last few years. Previously, you should say, okay, diabetes is there. You should have this level of blood glucose for everybody. You have anemia, hemoglobin has to be this level for everybody. Now for glycemic control, at least, we have individualized targets, not the same thing for everybody. If it's a non-pregnant healthy adult, an HbA1c of less than 7% would be sufficient. A healthy elderly person, you don't want to target that low. The risk of hypoglycemia in such a patient is much higher than the risk of hyperglycemia. So your target will be around 7.5. If somebody with very poor health status, very elderly, you may even be happy with a HbA1c of 8%. So it is individualized. When it comes to the time in range concept, this is a fairly newer concept. But it is not very easy because you have to have a continuous glucose monitoring. There are machines which are available, sensors which are available for that. With a Bluetooth, you can download this sort of a graph into your phones or computers. 70% of the time you should have in range, less than 4% below range, and less than 1% in very hypoglycemic states. This is the current guideline for your glycemic goal. You can see that as the duration of diabetes increases, you don't want to become very tight in your control. As the potential risk of hypoglycemia increases, you want to be very lenient with your diabetes control. As the life expectancy becomes shorter, you become more lenient. Where more comorbidities are there, you become more lenient with your, more liberal with your diabetes control. The more and more complications, you have less tight control. Of course, patient preference is also, and the resource and support system. A patient whom you advise insulin for better glycemic control do not have the resources for that, do not have anybody to help. Today also we had a patient who found it, staying alone, found it very difficult to take insulin by herself. How do we manage such a person? So in such people, it will not be the ideal control, but
Thanks to
rather
our life, no?
the control that will be possible. You are familiar with the different classes of drugs. I'll not go into this. I am just familiarizing you with this.
No,
flowchart.
camera with
Looking very complicated. I'll be explaining this.
This
But
is
still the ADA 2022, which came in December 2021. That time, this was the guideline that has come. I'll just, the guideline had mainly 6 factors. How do you decide what drug to give to a diabetic patient, type 2 diabetic? 6 factors are important. 3 on one side and 3 on the other side. 3 on this side are what? Does the patient have atherosclerotic cardiovascular disease, which can be coronary artery disease or cerebrovascular disease or peripheral vascular disease? Does the patient have heart failure or chronic kidney disease? These are three on one side. On the other side, is there any weight concern? Is there obesity? Is hypoglycemia a concern? Is cost a concern? This was still January 2022. Of course, the new consensus has changed a little bit on the right side. The left side remains the same. So how do you choose? Step one, according to ADA 22, I am saying first, then I'll come to the latest thing. There is mild change. First thing is always lifestyle modification for everybody. Along with that, the first drug in any type 2 diabetics where there is no contraindication for metformin was metformin till last month. But I am thinking that most likely the ADA 2023 guidelines, which will be coming out in the next month, will change that thing. Till now, it was metformin as the first choice of drug for all type 2 diabetics. It is going to be optional, most likely from the next month onwards. Step two, if the patient has got ASCVD, heart failure, or CKD, that is the next step you have. If they have one of these, you go to step 3 and ask this question. If the patient has got any vascular disease, a GLP-1 receptor agonist or SGLT2 inhibitor would be a best option, which means liraglutide, exenatide, that group of drugs. None of my patients are on these drugs because of the cost. SGLT2, now the cost has come down. Dapagliflozin, remogliflozin, ertugliflozin, canagliflozin, all these gliflozin group of drugs would be a good choice for those people. Those who have heart failure, the second choice after metformin would be again dapagliflozin or one of the gliflozins. Those who have CKD also, SGLT2 inhibitor up to a GFR of 20 can be used. This is the previous thing. If there is no ASCVD, heart failure or CKD, what do you do? You ask, is there a problem with hypoglycemia? Then what should we avoid? Avoid insulin, avoid sulfonylurea, avoid meglitinides. You can use one of the other things. Sulfonylureas are the glibenclamide, glipizide, glycoside, glipizide, all those group of drugs you should avoid. Is weight a problem? Obesity a problem? Then again, SGLT2 inhibitor and GLP-1 agonist, as on the left side, is better. If cost is a concern, of course, sulfonylurea and thiazolidinediones would be a good option. This is the existing ADA guidelines 2022, but there is mild change here. This is the current guideline come from the consensus statement. What change has happened, I'll just mention to you. The left side has remained the same, almost the same. This is the left side of the graph, ASCVD, heart failure, and CKD. The right side has changed a little bit. I'll explain to you what change has happened. This is the new guideline. So the first step, what has changed is that now metformin is not the mandatory first drug. You can still use metformin as the first drug. I'm not saying to stop metformin. Still, metformin is probably the most well-studied drug in type 2 diabetes. I would be the last person to stop using metformin because of the multiple advantages of metformin. Metformin has non-glycemic advantages also to the point of even preventing cancers. So metformin is a very good drug, but that is not, it was mandatory as the first choice till last year. It is most likely going to be optional from the next year. Step 2, almost the same. There is no major change, cardiorenal risk reduction. The step 3, the left side has not changed. You have the same options, but cost can be a major limiting factor for many of our rural patients. Many of them are, one, they are unwilling to take GLP-1 agonists, which are mostly injectables. The recently available oral drug is semaglutide, which is 300 rupees per tablet. So you can imagine how many people will really afford it. Okay. On the other side, they have changed that cost concern. Of course, this is a Western guideline. We should not be only looking at that. We should customize it for our patients, because that may not be very relevant. I was quite surprised that ADA all these years have kept that one column called cost concerns. That is really encouraging that ADA is looking at cost as a major predictor for health behavior. So for in the right hand side, they are saying you could use, one is a glycemic control, the other is weight concern. Glycemic control, metformin or any of the other drugs. If weight is a concern, again SGLT2 inhibitors and GLP-1 agonists are the mainstay. What is a pragmatic approach? This is something similar to what we've been following in our OPD. For all patients with type 2, if there is no contraindication for metformin, I would start metformin as the first choice. When metformin is contraindicated, I would use one of the gliptins, teneligliptin, vildagliptin, sitagliptin, one of them, or pioglitazone or anything, or sulfonylureas. Usually glimepiride is what we are using. Glibenclamide use in our OPDs have significantly come down to the point that we have stopped stocking in our pharmacy because of the severe side effects of hypoglycemia, very prolonged action. That's why glibenclamide has gone little out of popularity. Glipizide is a very good drug with short acting sulfonylurea, which also we use. As a second line, when metformin is not effective, you usually add one of the other groups. When the patient is not very affordable, I use DPP4 inhibitors or sulfonylureas. If there is a cardiac disease, we try to give dapagliflozin, which was 28 to initially 50 rupees per tablet, then came to around 24 rupees, 7 rupees, now even 2 to 3 rupees gliflozin tablets are available per tablet, which is worth an investment because of the multiple advantages of these drugs. When weight loss is a priority also, SGLT2 inhibitor. When hypoglycemia avoidance is a priority, take off sulfonylurea. Do not give glimepiride, glipizide, glibenclamide, glycoside, all of them you take out if the patient is going into hypoglycemia again and again. The other drugs do not usually cause spontaneous hypoglycemia by itself, but in a combination, of course, it can cause. Those who are, as a third line, when you are starting a patient with diabetes with the third oral agent, that time itself you start priming the patient about insulin. You may need insulin. It takes many visits of priming for a patient to finally accept for insulin. It takes many visits for the doctor also to be convinced about insulin. This is called insulin inertia that the physicians have as well as the patients have. So this is how we would currently manage a patient in our OPD. When to start insulin? When there is severe hyperglycemia, HbA1c of more than 10 and glucose consistently above 300, there is significant catabolism, weight loss, OAD failure. When 2 or more drugs have been used and they have failed, you should start insulin. When the patient is waiting for a surgery or something, immediate control, or patient has got mucormycosis, patient has got a very bad sepsis, immediate control is needed. Insulin is the answer. When the intake is unpredictable, you cannot keep giving oral agents. In pregnancy, most patients will need insulin, even though some guidelines still have retained metformin. Mostly the guidelines from the Eastern Asia, Singapore guidelines and all have still kept metformin, even though some of the Western guidelines have taken out metformin from pregnancy diabetes now. We still use metformin very much in pregnancy. So any patient with suspected type 1 diabetes also use insulin. The devices, you know, syringe is there, pen is there, pump is there, even inhaled insulin by name Afrezza is also available, not very popular. I'll not go into these areas. We are mentioning about the actions of insulin, rapid acting, short acting, intermediate acting, long acting, and ultra long acting has also come as degludec nowadays. There is just for information, there is a color coding which is standardized for insulin all over the world. A particular color will be there on the vial for a particular type of insulin. That is standardized around all nations, not only for India, everywhere. You can easily look up this on Google. There are different types of insulin regimens. If you have any questions, I'll mention that. But more importantly, I just want to mention one thing on the other 3 things. Blood pressure in a diabetic, how do you manage that? More than 140/90, you should start a single drug. If more than 160/100, 2 drugs have to be started. You can start in our medical college days, we were taught about hypertension. We were told about A, B, C, D. A for AC inhibitor and ARB, B for beta blocker, C for calcium channel blocker, and D for diuretic. Now the B has been taken off in the last 15 years. No more B in the first line management of, no beta blocker in the first line management of hypertension. It is true for diabetes with hypertension also, but it is A, C, or D if the patient doesn't have any microalbuminuria. The moment the patient has microalbuminuria or diabetic nephropathy, it is always A, AC inhibitor or ARB. Always AC inhibitor or ARB in a diabetic with microalbuminuria. What should we target? I will just leave it at that. 130/80 if possible, 140/90 if not possible. I'll not explain on the risk scoring now. One word about ACE-ARB, because that is the most important drug in delaying the progression of nephropathy and also in control of diabetes in patients with control of hypertension in patients with diabetes. We have to monitor for creatinine increase or hyperkalemia. These are the ideal. These are from the consensus statements before, from 2004 ACE consensus statements had come. We do not, I have to confess that I do not follow this. Initially, I do a baseline creatinine. Later on, if required, I'll check it. Not for everybody, but anybody with a renal problem, very frequently we may have to check. That we do. But with a very good baseline values, we don't routinely check every 4 monthly potassium. We do yearly creatinine and potassium only. More than 30% rise of creatinine after starting ACE-ARB, you may have to stop it. This is a algorithm. I would go into that. How do you manage lipids? What is the role of statins and other drugs in diabetes? To put it together, I have just put it like that. For primary prevention, which means somebody has not had any ASCVD, no cardiac disease, no heart attack, no brain attack or stroke, no peripheral vascular disease, that is primary. Secondary is anybody who has had any of these. If you have had one stroke, one MI or unstable angina or peripheral arterial disease, what you are giving is secondary prevention. Secondary prophylaxis means everybody needs statins, irrespective of their LDL, unless very few patients where their LDL levels are going less than 70 also, you may have to reduce the dose. Otherwise, all patients with ASCVD need statins if tolerated. What is the primary prophylaxis? A patient has not had, a diabetic patient, but never had any problem with heart or stroke or peripheral vascular disease. Such patients also, if they are above 40 years, generally they will need statins. Intensity of statins is the dosage that we are meaning. I'll not mention that. There is something called moderate intensity in statins, that is the dosing which is lower, and high intensity statins which the dosing is higher. In less than 40 years, only if there are additional risk factors, you need to start statins. Above 50 years, you may have to make it into high intensity statins if there is a high risk for ASCVD. At any age, if the risk for ASCVD goes very high, the LDL reduction has to be very aggressive. Sometimes along with statin, some other drug like ezetimibe or something may also have to be added. But if you forget that also, it's fine. Just remember, any type 2 diabetes patient above 40 years is a candidate for statin therapy. That much is the take-home message from this slide. There are various calculators available. The MD Calc is what I personally use. I'm sure many of you are using various different other calculators. Medscape gives very good calculator. One of the calculations is the ASCVD score, the atherosclerotic cardiovascular disease risk score. That will give you an idea. At the end of, you just enter the patient details into your phone in a ASCVD calculator. It will give you statin is needed, not statin is not needed. Here you can see I have just put an example where high intensity statin is recommended in a patient. You can just go by that. You always have your phone in your OPD. Just put the numbers. Immediately you will get it. Document the risk factor. Start the medication. So I use this. Of course, you should not quote me anywhere else. I use this shortcut for myself. I use this 40, 50, 60. Patients with diabetes more than 40 years start statins. Patients with diabetes, males more than 50 years, I ask whether this patient needs antiplatelets or not. When females with diabetes above 60 years, I ask that question. So I keep this in my mind like 40, 50, 60. I don't have any reference for those numbers, but I found it very useful. Finally, other agents which has got cardiovascular and kidney benefit. The major change that has happened in diabetic drugs therapy is something called a CVOT or cardiovascular outcome trials. It was in 2008 when one of the drugs, rosiglitazone, the relatively senior people will know, a drug which was very highly popularized, was found to have increased cardiac mortality. So then there had to be a lot of studies done for that. And it was not very high risk, but rosiglitazone was taken off the market, but pioglitazone continued. From then on, it was world over made a mandatory that any new diabetic drug comes into the market, they have to prove that this drug has got no cardiac side effects. Not only that, it has to be proven that this drug improves the cardiac outcome. This is called CVOT. This is a new concept which has come from 2008 onwards in the last 15 years. So if there is a new diabetic drug which is going to come out in the market in the next year, they have to prove that this drug is good for your heart also, not just for glycemic control. This is a new paradigm of thinking. In that context, SGLT2 inhibitors and GLP-1 agonists have come a big way. So it is not just about diabetes. That is why even though SGLT2 inhibitor like dapagliflozin and all came as an anti-diabetic drug first, now you are seeing that being used by cardiologists in patients without diabetes, nephrologists in patients without diabetes, because of the cardiac and renal benefits. Not only in diabetes, in patients without diabetes also. What are the another newer drug which is upcoming now is called finerenone. Finerenone is a newer brother of aldactone and spironolactone and eplerenone. This is a non-steroidal drug. This is the one which is mostly popularized in the last few months. It has come into India in this year only. Finerenone, again, little expensive drug, which has found to be having a benefit in reducing the progression of kidney disease as well as cardiovascular benefit. So there are various mechanisms that are told about this. It's a little different from spironolactone, thereby it doesn't cause so much of hyperkalemia. That is the advantage of that. There are various pluses and minuses of that. Finally, about antiplatelet drugs. I mentioned what the shortcut that I use, but this is always optional unless it is for secondary prevention. Any patient who has had a previous vascular disease, it has to be given. Antiplatelets have to be given. But those who have never had it, always discuss with the patient if they are educated enough to understand. There is a risk of bleeding. There is a benefit of no thrombosis. This is done by various studies, mainly the Physicians' Health Study from the US, where many of the physicians in the US were taking aspirin without any reason, just because they were above 40 years or 50 years. Many of them were taking aspirin. Of course, it is proven to be advantageous. But among those who are taking aspirin, doctors who are taking aspirin, they found that there was a much higher risk of GI bleeding. So it is plus on this side and minus on this side. You keep it before a patient who can decide, or decide for the patient with the best intention. You have to decide it for if they cannot decide for themselves. 2 antiplatelets may be needed in patients who have had an MI or had a stent put in at least for a year. It may be beneficial even after a year. So those who have increased risk, discuss with them, or you, with your best intention, decide for them whether they will be benefited by antiplatelet drugs. Just one thing about hypoglycemia I want to mention is the 15-15 rule. If a patient that you are treating with diabetes goes into hypoglycemia, symptomatic hypoglycemia, ask them to take 15 grams of glucose. That will be 3 spoonful, 5 gram, 5 gram, and 5 gram. Or if you are, the glucose tabs are available, which is 5 gram tablets like the Polo tablets or the old Poppins. The older people will remember Poppins, the Parley Poppins. Similar to that, there is glucose tabs which are 5 grams. You can take 3 and check the blood glucose after 15 minutes. If it is still low, take another 15 grams. This is the 15-15 rule for managing hypoglycemia. Of course, glucagon injections are available particularly for type 1 diabetic patients for treatment of 1 milligram subcutaneously you can give of glucagon. They keep it in their homes. So I'll stop here. If there are any questions, I would be glad to take it.
That's it. I want to thank Dr. Cijoy for his extensive sharing on diabetes, OP management. Please, so ask questions, only just 5 minutes. So only 5 questions. So you can ask fast. Then Dr. Cijoy will give the answers because we don't have time after that. Dr. Lane will take 5 minutes after that, where so our dinner is waiting for us. So please ask questions. You have any doubts? This is question hour only for 5 minutes. We are sorry, we don't have much time. After that also you can contact Dr. Cijoy over phone, and then we can give Dr. Cijoy mobile number also. Yeah. Because we don't have much time now. Yeah, please, sir.
Alpha glucosidase inhibitors, yes. Yeah, acarbose and voglibose. That's what you meant, sir. Carbos and voglibos, we had discussed previously a little bit on that in the previous quiz session. That is about decreasing the absorption, delaying the absorption. That is a very good add-on drug. I had mentioned it in the table. I didn't mention specifically. That is a good add-on drug. That the disadvantages would be some people with GI symptoms will have an aggravation of the GI symptoms with these drugs, because that reduces the glucose digestion. That is by inhibiting the alpha glucosidase. But that is also a good add-on drug for diabetes, type 2 diabetes. Somogi effect. Somogi effect is a phenomenon. Before we have to understand Somogi, we have to understand what is called dawn effect. Dawn means the dawn that we mentioned, early morning. Normally, many of our hormones, which are counter-regulatory hormones, because we don't have much control over diabetes. No, neither do we know much about diabetes, but the control over diabetes is very less because we are looking at only one side of the equation, insulin. But there are so many things on the other side: glucagon, epinephrine, norepinephrine, cortisol, growth hormone. All these are counter-regulatory hormones which will increase the glucose. We don't have any control over them. In the dawn, in the morning, that is the time where most of these hormones are secreted in large quantities. That is a normal phenomenon. So generally, in a person, the blood pressure and the glucose can go up in the morning a little bit, but still in a non-diabetic, it will still be within the normal limits. What happens in a patient, particularly somebody taking OADs or insulin in the night? Sometimes you have a patient who is coming with early morning hyperglycemia. Say the blood glucose fasting level is 200, and the subsequent levels are all normal. After in the afternoon, in the morning, all those levels are normal. You are finding only fasting hyperglycemia. So we have two thoughts about it. Is it because of the dawn effect? Because the hormones are more in the morning, is that why it is happening? That is one possibility. A second possibility in a patient who is taking drugs from outside, not physiological, is a pathological problem created by our treatment. You give an insulin or something in the night, which created a hypoglycemia at around 2 a.m. or 3 a.m. Thereby, the body will respond to hyperglycemia by increasing the counter-regulatory hormones, adrenergic stimulation, and then you find the fasting blood sugar to be very high. This is Somogi effect. Dawn effect is the physiological increase in the morning. Somogi effect is the pathological increase in the morning due to a hypoglycemia which was undetected in between. So what do? You ask them to do, if they are in hospital, we ask them to do a 2 a.m. or a 3 a.m. blood glucose. If that is very low, what we are dealing with is Somogi effect. If that is high, what we are dealing with is dawn effect. If that is high, increase the night dose of insulin. If that is low, decrease the night dose of insulin. You will find paradoxically that the fasting blood sugar will come down. Yeah, I'll tackle that. Yeah, tell me, please. Yes. Yes, very good. Thank you. ASCVD calculator is from 40 years above, but the ADA guidelines, the current consensus also gives when do you start for patients below 40 years. When you have two additional risk factors over and above diabetes, that is the patient whom you may start. They have mentioned that. If you are not able to use ASCVD, you can do two things. One, you can use Framingham. Framingham risk scoring is another one, which starts from 30 years onwards. There are some other scorings called Reynolds scoring and all, where age is not an issue. Another thing is to attribute, a patient is only 32 years, but you are attributing that patient 40 years and then do the ASCVD calculation. If that is high, you still consider that is a risk factor. That is low, it is telling that even if he was 40 years, it is still low. If it is high, it doesn't really help us, but at least when it is low, it helps us very much. So these are the two ways, additional risk factors also. One question has come in the Zoom, that is UTI very common with dapagliflozin? Theoretically, very much possible. I have seen 1 or 2 patients with on dapagliflozin with UTI recently, but I cannot really say that it was due to dapagliflozin, because so many other diabetes who are not on dapagliflozin also, we are constantly treating UTIs in them. But theoretically very much possible. Why? Why is UTI more common? Because the very mechanism of dapagliflozin is to send glucose through the kidneys, glucose out through the kidneys. So if you do a urine sugar for a patient who is on dapagliflozin, it will show 3+ or 4+, and the blood glucose may be only 120. That is because the mechanism of dapagliflozin is sending out glucose through the kidneys. So there is theoretically an increased risk of UTI, and most of the studies also have shown that there is increased risk of UTI. But is that a contraindication? Not so.
Thank you very much, Dr. Cijoy. And then I think, so I can sense your interest and questions going on even 10 o'clock without waiting for the dinner. So I want to thank you for all your interest on diabetes. I would like to help you by giving his mobile number, Dr. Cijoy, for the doctors who are coming from outside the CF hospital. If you want to take, just I am telling his number, our Dr. Cijoy diabetologist, 99-409-38972. The doctors coming from outside the Vatanchitram. You can call Dr. Cijoy at any time. We are happy to have you, or phone also. 99-409-38972. With this, we'll conclude this talk. So once again, we want to thank Dr. Cijoy for his excellent talk. God bless you. And then now this another 5 minutes, if you don't mind. After that, we are going for dinner. So this is my time to welcome Dr. Lenny, just to tell the scope of Diagnostic Center, CF Hospital Service Center, CM Insurance Scheme. We don't take much time. I am sure only 5 minutes. After that, we are going for dinner with word of prayer closing. Over to Dr. Lenny.
As most of you know, we are an institution here who try our best to give the best treatment to those who cannot afford. So we are into this insurance scheme to a large extent, and now we have got this diagnostic center. So diagnostic center, basically, as you know, it is for doing tests. So we have got approval as a diagnostic center for various tests. So whatever is shown in red, so we can do an angiogram here under the scheme. We can do echo and we can do CT scans. Then we can do these ultrasound guided biopsy, emergency ultrasounds or special ultrasounds, color Doppler, then these basic tests, LFT, RFT, thyroid profile, then bone marrow study, histopathology examination. We have a in-house pathologist, and so these are, so just I would describe the procedure. So if your patient has got a card, the patient has to be registered through a government center, and the government doctor has to sign and stamp the filled form with the hospital seal also. So there are various tests, various forms are there. I have actually kept up the letter pads with these things printed. Those who are interested can take that. So we plan to actually give it out to doctors. You can send your patients, provided they have the valid card, we can do it. So contact our insurance room, number 136 in working hours. If sending any emergency procedure after 5 p.m., I have given the numbers in that. So you are welcome. So emergency ultrasounds or scans also, we'll try to do it. So here we will verify that the card is valid. We'll upload copies of the documents, and then it has to be approved. So usually the approval will come within hours for a DC. It need not be like for 1 day or 2 days like for the inpatient procedure. So we will liaise with the doctors or staff in the cath lab or scan room or whatever area. And once the approval comes, we will send it to the respective area and do it. So these are the forms. This is for angiogram. This is for echo. This is for CT, MRI, ultrasound emergency. This is for LFT, RFT, thyroid profile. Then this is for bone marrow study. It's for histopathology and diagnostic scopies. Then this is for USP guided procedure. These forms are there, 7 different booklets are there. So we plan to give it to government doctors and doctors who are interested in sending their patients here for getting the test done free. So that is the flow chart. So this I have given to our doctors. So even here we may request help from some government doctors, because if a patient comes here also, the patient can't afford and we would like to do the test free for the patient. So expecting cooperation from everybody. Thank you so much for patient listening at the end of the session with empty stomachs. Thank you.
Thank you very much. I think we'll go for dinner. I thank the IMA branch who has very voluntarily sponsored the dinner. Yeah, over to Dr. Susan in a closing prayer and we'll join for welcome for dinner.
Shall we pray? Father, from whom all blessings flow, we thank you for this evening that we could gather together. A long evening it has been. We thank you for the dignitaries who have come, friends who have come from different places. We thank you for the scientific session we have had and the enjoyable evening that we've had. Thank you, Lord. We are a privileged group to learn about the human being. I pray that we would use this privilege with wisdom, knowing that we treat people who are needy. Help us, Lord. Bless the food that is before us, and we ask this in your precious name. Amen.
Thank you.